Anywho, welcome. Today we're discussing VenomVet Plus 101, a new anti-venom coming to the market. This presentation is by Kristin Lake, who is an experienced vet tech educator in emergency and critical care, volunteer vet tech mentor at Possibilities. And I'm looking forward to hearing you speak a little bit more about this. Kristin, I always say no one can introduce themselves better than themselves. So with that, I'd love to pass it over to you.
Sounds good. Hi, everybody. I'm Kristin Lake, and I'm an emergency and critical care veterinary technician. I've been working in the field since 2003, so 21 years now. I have been through pretty much everything you can imagine in the field, from general practice to equine medicine, mobile medicine, orthopedic and neurosurgery, and emergency and critical care for domestic and exotic animals, including anesthesia. I released my first book in 2023, The Veterinary Technician's Guide to Emergency and Critical Care, and I'm the founder of VetMed Math as well as VetMed Rounds, which are veterinary-specific inpatient rounding books that are available on Amazon. In my free time, I enjoy spending time with my three cats, Remy, Gemma, and Mila, which is named after my favorite tubing company. Okay. So let's see here. There we go. All right, so we'll jump right into this. VenomVet Plus is a purified bivalent Fab2 fragment as in VenomVet, and VenomVet Plus is a polyvalent antivenom using the venoms from various snake species to create a proprietary antivenom effective against all varieties of United States rattlesnakes. So even your pygmy rattlers, things like that, copperheads and water moccasins, all crotolines. Because of its polyvalent character, it is effective in immunological cross-neutralization. Clinical trials at Colorado State and at University of Florida are wrapping up, and it's expected to be released in 2025. All right, so the overview of VenomVet Plus, it's equine in origin. There's 10 ml vials. It does need to be refrigerated, but it has the maximum shelf life that the FDA allows for any drug, which is 3 years. The VenomVet, VenomVet is the precursor to VenomVet Plus, but the VenomVet adverse event rate is 2.6%, which is the lowest adverse event rate of any antivenom on the market, according to a 2021 JAVMA article by Sarah Carottenuto. And the VenomVet anaphylaxis rate is equivalent to less than 0.01%. And VenomVet Plus adverse event rate has not been publicized yet by Antivenom. When it does, I'll be updating this, but it's probably got to hit the market and get some more clinical trials out of the way. But from what I understand from Dr. Walliver down at University of Florida, who's running the clinical trials, it's all very similar, the numbers. Okay, so it's FDA approved for usage in dogs, cats, and horses. This is different from VenomVet, which was only approved for dogs. It was all other species were off label, but I have used VenomVet in a cat before, and everything went extremely well for that kitty. And let's see here. This also is approved for horses. So we know that a lot of horses end up getting bitten, especially in the Southwest. So that's really great that we've got that option now. It's FDA approved to give, VenomVet Plus is FDA approved to give to puppies and kittens of the following ages: greater than or equal to 12 weeks of age for dogs and greater to or equal to 16 weeks of age for cats. All right, something new from VenomVet versus VenomVet Plus. VenomVet Plus, less than 60 mils is needed for appropriate dilution to initiate infusion. So you would have 50 mils of 0.9% NaCl, saline, and to 10 mils of VenomVet Plus, which is the full vial. Sodium chloride is the only diluent that is FDA approved for use. However, other crystalloids such as LRS have been used during clinical trials and have had no adverse events related to dilution. But it will stipulate on the instructions just to use saline. Let's see here. So VenomVet Plus was designed to give the starting dose for 30 to 60-minute infusions according to AHA's fluid therapy guidelines, then titrate up accordingly to give the diluted 60 mils over 30 minutes, which is 1 hour. For dogs, this is 2 to 6 mils per kg per hour. In cats, this is 2 to 3 mils per kg per hour. I understand that AHA has updated its fluid therapy guidelines as of this year. This is based upon, I believe it was the 2017 fluid therapy guidelines, because this drug has been in the pipeline for a couple of years now. Let's see here. All right, so it can also be given over 30 to 60 minutes, depending on the severity of envenomation, and has been given to cats over 30 minutes with no adverse events. So that's really great to hear that we've got this option now that cats are able to basically be on the label for, and we can give it according to the severity of their envenomation, and the 30 minutes is something that's preferable for severe envenomations. All right, so calculating a VenomVet Plus infusion according to AHA's fluid therapy guidelines in dogs and cats, we've got an order of 3 mils per kg per hour for a 3.3 kilogram cat. We don't know our rates yet, and the fluid is 10 mils of VenomVet Plus to 50 mils 0.9% saline, and the time of infusion is going to be 1 hour. It's important that I walk you through the actual math portion, because we have to convert from mils per kg per hour to mils per kg per minute. So 3 mils per kg per hour times 3.3 kilograms gives us 9.9 mils an hour, or 10 mils an hour for our first 10-minute increment rate. But we need to convert 3 mils per kg per hour to mils per kg per minute in order to get our volume infused and be able to set our pumps appropriately. 3 mils per kg per hour divided by 60 minutes an hour is 0.05 mils per kg per minute. 0.05 mils per kg per minute times 3.3 kilograms equals 0.165 mils per minute. 0.165 mils per minute times 10 minutes equals 1.65 mils, and that's our volume infused, and our rate is 10 mils an hour as we've previously calculated. Okay. So we keep doubling each increment. So the 0.165 mils per minute that we used in the first problem, we carry it over and multiply it by 2, and that gives us 0.33 mils a minute. 0.33 mils a minute times 10 minutes equals 3.3 mils volume infused. 10 mils an hour times 2, 20 mils an hour. So that is the same for the problem below and number 4. And we do this down to number 5, but we stop there. So which one can we repeat to get us to about 60 mils an hour in 1 hour with titration? Our volumes infused through all of those problems give us 51.15 mils of about 60 mils. So 60 mils minus 51.15 is 8.85. 40 mils an hour to it equals 6.6 mils volume infused, which is the closest to 8.85 mils. And we want to repeat the 40 mil an hour twice to get to about 60 mils infused in 1 hour with titration. Now, you could just go ahead and make it easy and, go ahead and do 60 mils an hour divided by 6, because there's 6 10-minute increments in 60 minutes, 10-minute increments in the problem. But the thing is that there's no titration with that, and it's recommended to titrate it up. Oh, there it is. Okay. All right. One of the new things is that it can be bolused as well. VenomVet Plus is able to be bolused and given as an injection in severe envenomations with no dilution necessary at all. However, this is considered by the USDA as an off-label usage, as the clinical trials did not specify this method of the product in that aspect, although it has proven to be safe in trials at University of Florida. Since it's considered an off-label use, I would allow the bolus of 10 mils of VenomVet Plus. It's pretty much the perfect solution for small patients and patients with comorbidities that can't tolerate 60 mils of fluid volume with a diluted infusion, or in very severe envenomations where time and fluid are limited. This is from Dr. Walliver's presentation. These are important things to not do in a snake bite situation. We've got Benadryl here, cutting, sucking, the venom out, extraction devices, fresh urine, aged urine, Dr. Walliver's urine. You'd be surprised what people ask that they can put on a snake bite. And it's not like it's, what are they? The jellyfish that sting you, the man-o-wars. So it's funny that people, ask about turpentine, gasoline, bleach, gunpowder, bacon fat, any kind of animal fat, lard, raw eggs, lemon juice. But I just wanted to show that for some comic relief here. Okay. So what's really important that I notice in snakebite envenomations, the way that they're treated, is that there is very little consensus. This is from National Snakebite Support Group, and it's the first veterinary consensus on what should be utilized in snake bites and what literature and human medicine also suggests for snake bite treatment, and when it comes to our patients in veterinary medicine. So the contraindicated, do not administer, and not indicated of no benefit sections go against what many veterinarians have been taught about snakebite envenomation treatment, but the literature suggests otherwise. NSAIDs, corticosteroids, sub-Q fluids, diphenhydramine, which is Benadryl, and broad-spectrum antibiotics, Unison, Baytril, Cefazolin, and others are all contraindicated or have no benefit. So do not give these treatments to any snakebite envenomation patient. If there is a wound that is slowly necrotizing, it needs to declare itself. And at that point, yes, maybe some Unison, Baytril, Cefazolin is useful in those situations, but it's pretty rare that that's the case, except in severe envenomations. The way that we tell that there is a severe envenomation is through a blood film, as well as clotting times. So your coag panel is going to tell us basically if there's a severe envenomation with the echinocytes that are visible on that blood film, and how many echinocytes are affected, or how many red blood cells are affected and effectively turned into echinocytes on that film. All right, so the only things that we should be giving that's indicated is antivenom, because that's the only thing that can neutralize the venom itself. IV fluids, so we want to basically control patient hydration, but also blood pressure. One of the ways that venom works is to go ahead and try to tank the blood pressure, so that the prey dies, basically. So that's one thing that we need to really make sure that we're keeping an eye on. Pain management, always, as soon as they come through the door, you need to be giving methadone, hydromorphone, something along those lines to manage their pain, fentanyl, and with a fentanyl bolus with the fentanyl CRI setup, things like that. Let's see here. And then blood work, we're talking about CBC Chem 17 lights panel, as well as creatinine kinase, your CK panel, as well as the blood film and coags. Those are your baseline blood work options, basically. But UA is also of interest when it comes to snakebite envenomations that are severe, because rhabdomyolysis can affect those patients. You just don't want to actually poke the bladder via cystocentesis in order to obtain that urine. You want to either pass a catheter or you want to go ahead and get a free catch. All right, so contraindicated, do not administer NSAIDs, nonsteroidal anti-inflammatory drugs, including but not limited to carprofen and meloxicam. It can increase bleeding and bleeding tendencies, and we know that venomous snake bites already are acting upon the clotting cascade. Let's see here. Bleeding risks are already increased due to venom effects, and NSAIDs can also cause significant kidney injury. So corticosteroids, including but not limited to dexamethasone and prednisone, increase the risk of delayed healing and gastric ulceration perforation. When combined with NSAIDs, the risk of septic peritonitis and potentially fatal GI bleeds is even higher. Subcutaneous fluids, administering fluids under the skin causes some bleeding. The tendency to bleed is already increased due to the venom. Human medications can be fatal to pets and should never be administered except as instructed by a veterinarian. Home remedies, there are no effective home remedies for pit viper envenomations. Some home therapies may cause additional harm and complicate and prolong proper veterinary treatment. And the two things that are not indicated or of no benefit, Benadryl, I see a lot of people give this, even, the guys over at Critter Fixer, which, fixes everything under the sun, species wise, they're still giving, Benadryl and steroids along with their anti-venom. So these things are still pretty prevalent in daily practice, but it's not necessary. Benadryl is an antihistamine that is useful in treating swelling and inflammation mediated by a body chemical called histamines. Histamines are released by the body in cases of allergic reaction in response to bee, wasp, and hornet stings. Swelling from pit viper envenomation is caused by massive tissue damage mediated by hemotoxins, cytotoxins, and myotoxins, not histamine release. Using antihistamines to address swelling related to snake venom is of zero benefit and may cause dangerous altered mentation in patients experiencing shock. For antibiotics, as I explained earlier, they're prescribed during the initial treatment of prescribing them during the initial treatment of envenomation is unnecessary only if infection has been diagnosed. All right. This is the national snakebite support algorithm for treating snake bites. So we start up here. We want to go ahead and perform a full physical exam, shave the bitten area if it's known where the animal was bitten, and obtain our initial lab study, CBC with a platelet count, chemistry, coags, blood film to confirm platelets, echinocytes, and creatine kinase, and the blood pressure as well. It's really key that we are monitoring blood pressure. If you end up having a patient that has a high blood pressure, that's related to pain. So we need to adjust our pain management strategy because otherwise we should just be dealing with low blood pressures in these patients. Okay. So checking for signs of envenomation, puncture wounds, pain, bleeding, bruising, swelling, redness, hemotoxicity, prolonged coags, low platelets, systemic signs, hypotension, shock, neurotoxicity, bleeding, severe pain, vomiting, and or diarrhea, early immediate necrosis, and monitor for pigmenturia. Avoid cysticentesis for your analysis, as I explained. Check for indications for antivenom, which is progressive swelling or significant local tissue injury, hemotoxicity, which are prolonged coags, low platelets, and any systemic signs. A mild and moderate and severe case of envenomation, you want to go ahead and see box 12, which is over here. If a patient is stable, you want to apply you want to go ahead and put in an IV catheter, administer analgesia that's fully reversible, opioids that are preferred, and start IV fluids. Even if they're euvolemic, you may need to give a bolus here and there, and versus vasopressors, but honestly, I wouldn't, I have never had to give vasopressors even to severe envenomations, usually a crystalloid bolus, because it only lasts for like a few minutes. It waxes and wanes, I find. So I've never had to start anybody on vasopressors. Oops. But it is something that I'm more likely to move towards doing for those euvolemic patients in the future. Let's see here. So for mild envenomations, which are mild to moderate pain, mild to moderate swelling and bruising, normal coags and platelets, no acute bleeding, no hemolysis, no GI signs, that's all that we want to do. For moderate, we're seeing moderate to severe pain, moderate to severe swelling, bruising, prolonged coags, marked thrombocytopenia, mild to moderate bleeding. That's going to be our moderate envenomation. And for severe, we have an unstable patient, hypotension, obtunded neurotoxicity, dyspneic, severe bleeding, coagulopathies, vomiting, hematemesis, diarrhea, hematochezia, all of those kinds of things. That's why it is prudent to use a Foley catheter in severe envenomation patients in your worst case scenario kids, because that rhabdomyolysis can kick into effect. All right, so administering antivenom. Prepare antivenom according to manufacturer instructions. So VenomVet, it's dose based on severity of envenomation. For mild bites, which we diagnose mild, moderate, and severe via our platelets, our coags, and our blood film. And depending on those tests, for mild, you want to administer 1 to 2 vials over 1 hour. For a moderate bite, you want to administer 2 to 4 vials over 30 to 60 minutes. And for a severe bite, you want to administer 2 to 6 vials over no more than 30 minutes. We're not going to go over Rattler. This is just purely for VenomVet. You want to monitor for adverse reactions, just like a blood transfusion. And you want to see box 14 for those. Monitor for urticaria, angioedema, circulatory collapse, and GI signs are more common in dogs than cats. Respiratory distress is more common in cats. So if they're getting tachypnic, things like that, that's a problem. Treat allergic anaphylactic reaction with 0.01 mils per kg of epinephrine IM, and then a CRI at 0.05 mics per kg per minute, and titrate as needed. And then this is the case where you would give diphenhydramine as well, only in the case of anaphylaxis, 2 to 4 mg per kg IM plus minus an anti-inflammatory dose of steroid. That is the only time. And you don't want to preemptively give those either. All right, so you want to determine if control is achieved. So swelling and tenderness is not progressing, blood work is improving / resolves, you're clinically stable, neurotoxicity is improving / resolved. You have an option of yes, no. If the answer is no, you need additional antivenom. That will neutralize the venom load, and unfortunately that can be multiple vials. It is expensive treatment, but I'd prepare your severe envenomation patients for up to 20 vials, honestly. If your answer is yes, you're performing serial examinations, rechecking the swelling and wounds. You're pain scaling them. There's also a snakebite severity score scale. And that is something that's used in human medicine, but there is one derived for veterinary medicine. And I can pull that up. I'm not sure that I have it in this one, this presentation, but I have it in another one that goes over the different systems that's all affected to that pains, well, not pain, but snakebite severity score. Okay, so we're pain scaling them, blood pressure, rechecking labs in 4 to 6 hours, coags, platelet count, PCV total solids, or CBC at that point. We want to basically be checking our PCVs to monitor our hydration level. If patient develops new or worsening symptoms, you return back up to box 3. All right. So your patient's doing well, and you determine if the patient meets the criteria for discharge, which are no progression of venom effects, no unfavorable laboratory trends, and let's see here. Okay, so this mentions up here about dry bites. Do not administer antivenom. Observe patient for greater than or equal to 8 hours. Repeat labs prior to discharge. Those guys usually coast, and it's pretty obvious by the time that they've reached the hospital with their echinocytes, if there are any echinocytes at all, that it was a dry bite. Usually it's less than 25% echinocytes on that blood film for very mild or dry bites. Basically, you'll just see a few echinocytes here and there if there was just like a drop of venom, but mostly dry. And then for minor envenomations, you basically don't administer antivenom. You observe the patient for 12 to 24 hours and repeat labs every 4 to 6 hours prior to discharge, following this algorithm. So that's what I was saying. If there's like, a drop or two of venom that was injected versus, a full load of venom, those guys usually coast and, don't require antivenom at all. Oops. All right, so for our discharge instructions, you want to have the owners monitor for swelling, bleeding, redness, necrosis, infection, serum sickness, which is rash, vomiting, diarrhea, joint pain, and fever. Medications to go home would be gabapentin, tramadol plus minus on that one, but a fentanyl patch is a good idea, as well as codeine. I'm not a big fan of tramadol. Wound care with primary vet or the referral to a specialist if they do have some necrotizing wounds. Antibiotics are indicated where evidence of active infection is present. And for patients with severe envenomation, recheck blood work 48 hours post-discharge. All right. All right, so I can go ahead and take some questions now. I'm not a direct product representative of VenomVet Plus, but I'll do whatever I can to answer your questions. Does anyone have any questions?
Maybe I'll start, and maybe this will give everyone else the confidence to ask smarter questions. I'm gonna ask something. It's just because this is very new to me. And so
Yeah.
I'm curious about how these kinds of products, how they're manufactured. Like, are you using snake venom for, like, are you, how are you manufacturing this if you're like someone who's like
So
uh
it's equine in origin. So basically, it's a whole long drawn out process in order to go ahead and get the venom that becomes the anti-venom that we utilize. That's equine origin, but it's horses that are envenomated basically, and then their immune system goes ahead and mounts a defense, and that defense is then used to go ahead and create antivenoms.
interesting. Okay, I didn't
Hmm.
know. And then I know you mentioned that this is going to be approved for cats, dogs, horses.
Yes.
Are you seeking, or are the Venom Vet Plus folks seeking to get this approved for any other types of animals?
It not at the moment because it's off-label use, which we utilize a ton of drugs off-label for different uses and whatnot. But they basically have their points covered that we can it can be used in rabbits, it can be used in sheep, it can be used in all of these. And they expect for those animals to receive it as well, despite the fact that it's just marketed for dogs, cats, and horses.
Cool. Okay, that makes
Mhm.
sense. And then do you know, I don't know like what kind of audience we have, so I hope that this is relevant. Oh, we have a question here in the chat.
Okay.
So for Rocky asked, when is this expected to be released?
2025. It's been pushed back a couple of times now, and that's just because the clinical trials have been so lengthy and whatnot at Colorado State's large animal department, College of Veterinary Medicine Hospital, as well as University of Florida's small animal department at the at this companion animal hospital there. Basically we're looking at probably early to mid 2025.
Early to mid 2025.
Yeah.
Okay. Right. And then Annette asked, do you have any experience using this product in goats?
Not, I don't specifically have experience utilizing it in goats. The people that did the Colorado State um clinical trials, they do though. So that's why they're saying, we are more than, happy to go ahead and have this used off label because we know that it's effective in all of these different species. So
Okay. That makes sense. And then Christy asked, what has been found to be harmful as far as giving a single dose of dexamethasone? You did mention not doing oral steroids and NSAIDs, and that's a general issue with using meds together versus uh, an issue with specifically an issue with snake envenomations. Cost of the medication? Okay, so that's a few questions in one.
yeah, so cost of the medication is basically around the same as Venom Vet. It's probably going to go ahead and take over Venom Vet in the market when it comes out. But as far as giving a dose of dexamethasone, Dex SP, or just dexamethasone, the swelling, the cascades and whatnot that are being utilized, and all of these different mediators that venom goes ahead and causes to cause these effects in the body. We it doesn't make sense to go ahead and just basically go ahead and give corticosteroids or NSAIDs to bring down that inflammation, because that's not the pathway that the venom is causing it to cause that swelling. It's from tissue damage and necrosis and the release of all of these different things that is basically causing that swelling. So does that make sense?
So I hope so. And everyone who's asking these questions, you feel free to unmute if you want. I would love for this to be a back and forth, so we can have, you know, like follow-up questions as well, if anything comes to you guys as you're asking these questions. Oh, and
Yeah,
Chris.
I usually get a lot of questions when it comes to just, either giving it or and whatnot. That's why I made this section
Yeah,
kind of prolonged.
I was gonna ask, is there gonna be any sort of formal like training that's given out for this? Like, and if
This
so, what is
this
that?
would be it, this, and we would go off and go do our jobs after, witnessing, a webinar on it, and that's it.
Maybe you should be doing that webinar on it. Maybe
Yeah.
this might be the official thing. And I think we were chatting earlier last time we met and talked about this, and you kind of discussed kind of what your relationship with VenomVet is and the people who founded this. I would love for you to kind of like talk a little bit more about that.
Yeah, so Dr. Gina Broussard is the director of the clinical trials at Antivenom, and huge thank you to her, as well as Dr. Corey Walliver at University of Florida, who have both kept me in the loop as to what's going on during the clinical trials and how the drug's being utilized. So essentially, one of the biggest differences between VenomVet and VenomVet Plus is that we can bolus VenomVet Plus. So that 10 mils is very different from 60 mils total, going into a cat. So fluid overload, is not really an issue when it comes to VenomVet Plus, unless we've got a severe envenomation, we're looking at multiple vials, but or we've got hypotension issues and a dehydrated animal. But it's one of those things that is really a game changer and with this product. So being able to bolus just 10 mils versus having to draw it up and give it over a diluted, titrated, amount of time, that's all if you want to do that, but you're more than welcome to bolus this product.
Yeah, and bolusing seems like it would be a much more like targeted approach, and you
Right.
get a lot more of an effective outcome in that way, right?
Right.
That's exciting.
Mm-hmm.
Eh, oh, Chris, do you have a question? Yeah, feel free to unmute.
Yeah, so as far as cats, I know we use Rattler Antivenom a lot, and I pretty much don't use it because of the reactions I've seen in cats.
Yeah.
How many cats has this been done on and studied in order to determine its safety? Because whenever cats have a reaction, it's not just swelling; it is a
It's
severe
anaphylaxis. Yeah. Yeah, they're on death's door basically at that point. So yeah, I don't actually have a specific number to give you, unfortunately, of how many cats were in the clinical trials at UF. I can get you that number though. And if you just want to email me after this, that way I have a way to communicate with you. I'll ask Dr. Walliver how many cats were in the studies for you. But honestly, the reaction rate is for anaphylaxis is less than 0.01% for VenomVet, and we're getting the same amounts basically for VenomVet Plus. So
Yeah, and I saw that anaphylaxis rate was like 0.01 or something less
yeah,
than 0.01.
Is that rate in cats and dogs, or just
that's
overall?
across the board.
Okay, yeah, that doesn't help that much then.
Okay, so then
So much worse.
just email me. At the end of this, my email will be up on the screen, and I'll have a way to communicate with you, and I'll find out for you specifically what the reaction rate in cats was for you.
Okay. Sounds good.
Okay, thank you.
Yeah, let me put your LinkedIn, if you don't mind. Let me put your LinkedIn
Yeah, not a problem.
as well, so that we can all like connect after this as well.
Yeah.
Put mine in as well. I would love to connect with everyone after this. So that's Kristin's LinkedIn, in case, you know, when we get off this, you're like me and you have like 50 questions that come to mind after the fact. That's perfectly fine. Let me link my LinkedIn there too. I think I also wanted to ask about, I know, like you mentioned, you're going to be speaking for the Mississippi Veterinary Medical Association
Yes.
in the winter, right? I think those dates
Yes.
looks like February 28th to March 1st.
Mhm.
Are you able to share what you'll be presenting on?
Yeah, one of the things, hang on one second, let me stop sharing this real quick, and I'll go into the other presentation.
Ooh, are we getting a sneak peek?
Yes, you are.
Yeah.
But it's
And
how to triage snake bite and venomation cases, basically, because the triage process is a little bit different from the algorithm that I had gone through earlier with you guys, because it branches off into stable and unstable patients when they present. So let's see here. Let me get rid of this. Where is that? There we go. Okay. Beginning. Okay. So that's this. All right, these are the things that we'll be going over. What is VenomVet Plus and how does it work? Triage, stable patient versus an unstable patient, diagnostics, managing hypotension and hypertension in the snakebite and venomation patient, and calculating a VenomVet Plus infusion like I showed. How does it work? We'll go over that. VenomVet Plus is obtained from the blood of healthy horses that have been immunized with crotalline venoms. It is a polyvalent antivenom treatment that is produced under sterile and non-pyrogenic conditions using Fab2 technology. Third-party research provides that Fab2 is created by a pepsin digestion of purified IgG. It has a longer half-life and remains in the vascular compartment longer than Fab technology-based products. Another significant difference is that it has 2 antigen binding sites per molecule and works by binding and neutralizing venom toxins. Once neutralized, it facilitates the redistribution of the neutralized toxins away from the body, away from the target tissues, and they are eliminated from the body. From a safety standpoint, the technology fully eliminates the FC fragment. This significantly reduces hypersensitivity reactions during administration to envenomation victims. So that anaphylaxis rates basically is what is basically taken care of when it comes to reducing the hypersensitivity reactions we see by removing that FC fragment. So to triage a stable snakebite and venomation patient, you want to have the teammates gurney the pet inside and prevent the animal from mobilizing. Time is a factor, and venom can reach central circulation faster if the animal is mobile before treatment is initiated. You want to take a comprehensive history from the owner, including a description of the snake, if they saw it, and areas where bites may be located. The time frame of envenomation and time elapsed since venomation. If any first aid was administered and what kind. So if they're giving like human medications, we need to know that, because that's a whole other issue in and of itself. Names and dosages of medications given, and any medications regularly given and for what conditions. Previous pertinent medical history. Symptoms displayed in the time of onset and longevity. Full TPR with weight, physical examination by the doctor with full body check for wounds. Let's see here. IV catheter placement. Ideally, we want to be placing 2 peripheral IV catheters to start on 2 non-affected limbs, one dedicated to VenomVet, if we're diluting it, and the other for a blood draw off of the catheter for diagnostics, IV fluid resuscitation, and potentially fresh frozen plasma, if we need to go there, and place just an appropriate size catheter to the patient. Not like an 18 in a Chihuahua. Remember, bite wounds may be small and difficult to visualize, so shave areas thoroughly and examine briefly, but thoroughly before aseptic technique for IV catheter placement. 2 sets of eyes are best, but if you're 200% positive there's no bite wounds, then work quickly to get a catheter in. Let's see here. All right, this is just basically if 1 limb's available, 2 limbs, 3 limbs, and you know, how we would basically use those limbs in a worst case scenario situation. For triaging unstable patients, you just want to basically bring the animal in on a gurney as quickly as possible, ask the owner where known bites are located, and then bring straight to the back to the treatment area. Have another staff member discuss the historical items with the owner while taking a detailed notes and asking the questions under the stable triage section, while you and the rest of the team begin emergency stabilization procedures. Oh, shoot. Let's see. All right, those emergency stabilization measures are an ABC assessment, ECG leads on with ultrasound gel, oscillometric blood pressure, a brief exam, not a full exam, and blood draw off of the IV catheter placement for diagnostics and running diagnostics immediately. The reason why we want to run diagnostics immediately is specifically that blood film, because the blood film itself, the crenation can occur in an aging EDTA tube, and then also an EDTA tube that is underfilled will cause crenation. So that looks very, it's the same as a kind of cytosis. So in order for us to get a proper read on that, we need to know that has not occurred from an aging EDTA tube. The ABC assessment, if the airway is compromised, attempt intubation. If unable, consider emergency tracheostomy. I'm sorry, tracheotomy. If breathing and circulation is compromised, start compressions and intubate at this time with end-tidal CO2 hooked up to multi-parameter monitor. Perform 1 minute of 1 round of 2-minute chest compressions, then assess the patient for ROSC. If ROSC is achieved, then begin post-arrest care. If ROSC is not achieved, begin ALS immediately after assessment. When it comes to the ECG, the abnormal rhythms that we're seeing are VPCs, AIVR, VTAC, pulseless VTAC, and VFib, as well as some other abnormalities, you know, depending on the case itself. You might get like electrical alternans if you're on a table without any towel down, but things like that are what we're looking out for. Oscillometric BP, we trust it in surgery, so why not trust it in an emergency situation? Running serial BPs every 2 to 3 minutes. Brief physical exam on the table and brief check for bite wounds before utilizing limbs for peripheral IV access. Remember, bite wounds may be small and difficult to visualize. And then you want to place 1 to 2 IV catheters in non-affected limbs, depending on the doctor's orders. All right, so blood draw off of the catheter for chem, CBC, light, CK, PCV, total solids, lactate, BG, and create a stained blood smear for immediate analysis, looking for red blood cell echinocytosis. But as I said, crenation can happen to samples that are allowed to sit on the rocker in an EDTA tube in age, and crenation is also seen in samples that have been underfilled. So collect the proper amount and run right away. TFAST, you want to be evaluating for signs of hemothorax, which is blood in the thoracic cavity, as crocodile venom is hemotoxic, cytotoxic, myotoxic, and less commonly neurotoxic, even though there are some toxins in some rattlesnake venoms. Hypovolemia, a smaller than normal heart, can indicate decreased blood volume, and ruling out any other abnormalities. A thoracic X-ray may be warranted if abnormalities are found on the TFAST. If hypovolemic shock is suspected, initiate shock bolus aliquots under the doctor's orders with crystalloid fluids. Pulse ox if the gods allow it, but absolutely try. And then complete the TPR with the weight. This is basically a way, it's the Beagle rule for how to go ahead and estimate a patient's weight before weighing them, so that you can kind of get some initial things on board if they're that unstable. And then plus minus thoracic radiograph, when stable or able, evaluating for signs of hemothorax, blood in the thoracic cavity, and severity, as crocodile venom is, as I said, hemotoxic, cytotoxic, myotoxic. Also evaluating for hypovolemia and ruling out any other abnormalities. Let's see. The diagnostics, this is what a kynocytosis looks like on blood work. On the blood film, these little projections. Okay. Spherocytes here basically tell us if they're there, the level of severity has increased basically for the envenomation if we're seeing spherocytes. And hemolysis, same thing. The level of severity increases if we're seeing hemolysis, which is the breakdown of the red blood cells.
I'm also seeing a question in the chat real quick. Sorry to interrupt.
Yeah,
I'm
yeah,
seeing
let's go ahead and do it.
Yeah, I'm seeing a question from Christy asking, have studies been done concerning how long after envenomation antivenom can be administered? It used to be 24 hours, and I've heard up to a week later. Does that still apply? And
Yes,
then,
it does.
oh, cool. Okay.
Yeah. So basically, it is up to about 3 to 5 days. I would say not a full week. And that is from anecdotal evidence, I would say, versus actual literature. And that's because some of the animals that were tested at University of Florida for the clinical trials had some delays in getting to care and are included in our numbers and whatnot for this product.
Okay, and then I'm also seeing, what are the indications for FFP?
Oh, indications for FFP. Let's go to that real quick. Let's see here. Hang on 1 second. All right. So basically, for FFP, you'd be trying to manage their hypotension, and an epinephrine or norepinephrine CRI would be refractory at that point in time. Sorry, and where is the little thing? There we go. Yeah, where the hypotension would be the major factor, because and also bleeding, if we need to kind of stem some bleeding, and then our clotting times are prolonged, things like that, then we need to be using FFP or packed red cells, depending on what the labs show.
Okay. And it looks like we're running short on time. I appreciate this early preview. We may need to have you back as another pre-party before your sorry, this is my cat Chandler. For the before the winter conference or maybe before the summer conference that you're
Okay.
going to be presenting at. But either way, you know, one last chance if anyone wants to ask any questions in the chat. Otherwise, we're going to sign off. But before we do, I have a link I want to share with you guys. And so far, this is being shared with you guys only. We're working on a little project at Celeritas. That's an AI assistant for veterinary clinics. Hi, Chandler. And we're going to be doing some free trials for a select group of clinics. So we have a survey right now just to kind of gather information from potential collaborators. I'm going to put that in the chat for anyone who's interested. That's going to involve a few different tools that we have that are going to help with optimizing clinic operations, automating marketing activities, streamlining financial reporting, and AI-powered veterinary research. It's a fun little thing that we're collaborating with quite a few people on. And so if you want to get on that early, get on it free, help with building it through some of the feedback you're giving, like feel free to click on that survey link I just posted in the chat. We would love to work with you guys on some early versions of this. And with that, is there anything you'd like to share, Kristin? If you'd like me to share your an email in the chat or?
Yes, I'll put that in right now.
Great. And thank you again so much for this presentation.
Absolutely.
We're neighbors too, right? You're in
Yes, I'm in Delaware.
Oh, you're in Delaware, right? Okay. And I'm calling in from Philadelphia. I don't know if we have any other East Coasters here. I know we have people out west represented. You know, I try not to think about needing anti-venom in the East Coast, Philadelphia. So maybe I'm sheltered. I'm like, I'm not gonna see anything crazy here. But
Well, I'm from Fort Lauderdale, so
there
yeah.
you go. Okay, so you're like, this is born and bred into you.
Yep.
Okay. Well, there's the email. Thank you everyone again for joining. It was so nice to meet
Yes.
you all.
Absolutely.
And thank you, Kristin. Thank you, Chandler, for the special appearance. Okay, I'll see you all next month. Have a
All
good
right,
rest
thank
of the day.
you.
Bye, everyone.